I'd like to introduce Dr. Nathaniel Gleason, an associate professor of clinical medicine in the Department of General Internal Medicine at UC San Francisco, the medical director for practice innovation at UCSF Health. Nathaniel attended UCSF for his medical degree and residency training in general internal medicine. I don't know if you know, Nat, that you and I did the same residency program, although I think I might have been before your time. Um, he serves as medical director for practice innovation. He's focused on innovations that improve access to timely, high value care in the outpatient setting. He developed an e-consult program at UCSF, which offers primary care providers timely access to specialty expertise and allowing patients to avoid travel, work absence, and other costs associated with a visit to a specialist office. And he's received funding from the UC Office of the President and a Medicare Innovation Grant with the Association of American Medical Colleges. He leads dissemination of this e-consult platform across the entire UC Health Systems, which is a huge system, and additional academic medical centers nationally. And the implementation grants provided firsthand experience leading teams at each campus to understand barriers and facilitators of adoption of innovation by providers and the iterative refinement of the user experience of new tools and services. And I think an interesting thing about Nathaniel is that he seems to accumulate administrative titles and responsibilities in a progressive fashion. And I'm sorry for that. So with that, I welcome you, Nat. Thanks for being here.
Thank you, Pete. This is such a privilege. Well, this is amazing. I'm just totally humbled and thrilled to be a part of this. Thank you. Incredible opening remarks, Pete and Holly. Gosh, what an amazing setup of just the essential issues and the background, and just the most timely talk. Also, that was amazing. So, I am a general internist. I practice primary care at UCSF. I am soon to be our executive medical director for primary care. And I'm going to tell you a little bit about my own story. And then I'm going to try and fulfill the title that Pete gave me, which is around the importance of professionals, medical professionals with disabilities in the healthcare environment. And that's a tough one, it turns out. I have a lot of strong feelings and have thought a lot about this, but it's an interesting case to make. So I hope you'll go on this little journey with me. So what we're going to do is we're going to consider the potential impact of professionals with disabilities in healthcare. But before we really get to that, I want to define disability in a way that I find personally really useful. We're going to talk a little bit about the prevalence of disability in the population and some recent insights into how interesting ways to think about that. And we'll talk a bit about disparities in care for patients with disabilities. And then we'll talk a little bit about access to care. And I'm going to start first with my own story because I think it is really germane to the topic. Actually, I'm going to start first with, as the conference organizers asked us to, with a few questions for the group, just to get you started in thinking. So the first question, I'll follow Holly's lead. I won't necessarily give you the answers, but what age group includes the largest absolute number of people with a disability? 55 to 64, 65 to 74, 75 to 84, or over 85. So we'll get to that. What is the number one predictor of developing a disability between age 50 and 65? And the choices are arthritis, depression, stroke, and low income. And the last question is, what percent of primary care offices in California are fully accessible to a wheelchair user? And the choices are 34%, 49%, 66%, or 88%. So I have a condition called achromatopsia. I have no functioning cone cells. And I'm going to try and represent what that means and describe it for anyone who can't see the pictures. We're looking here at a couple of young girls, one of whom's my second cousin, on horseback, and the picture is very faded out, kind of blown out, super overexposed, and black and white. So I'm going to try and walk through what the implications are. So cone cells, as many of you know, are the cells we use to see daylight and to see color. And they also turned out to be just a much more refined. They are how we do detail. The fovea was 50% of the neural output from the eye, and it's all cone cells, and it's just like 3 millimeters across. So the cones are the important contributor to visual acuity. It's my little attempt to represent this. We have this image of the same 2 girls on horseback. Now they're in color and clear with normal exposure. And I want to just zoom in here on one of the girls so you can get a sense of the level of detail that you see. So you can see everything about her face, really get a sense of like what she's doing and what she looks like. She's holding the reins. You can see a necklace around her neck. I've now made the picture black and white, so I have no color vision. And now I've overexposed the picture. So with the cone cells, they're your daylight vision cells. And so without them, I'm dependent on my rod cells, which means that when I walk out of a dark, it's the equivalent of when you walk out of a dark room or a dark movie theater into that bright sun, and for just an instant, it's really painful and really bright. And then your cone cells kick in and your brain just ignores the rod signal. But for me, I only have the rods. So that experience of that super bright, intolerable light where you really can't functionally see anything is the norm for me. And now I've just zoomed away from the girls so you get a sense of the acuity problem is a little bit hard to explain because it's not blurry, but it's just the level of detail is not there. So now you really can't see this young girl's face, facial expression, necklace, or anything like that. So that would be more my experience, whereas the close-up would be more of the normal experience. And the same thing goes for reading. I am very fortunate. I have about 2400 acuity, and if I get really close to most standard print, I can read it. But the really close part turns out to be important, as we'll talk about on my journey in medical school. This is a picture of me as a boy, just because it's so silly. I have these big dark red glasses. The red turns out to cut down the light from that the cones are most sensitive to at the wavelength the cones are most, at the wavelength that the rods are most sensitive. And there's these big side shields that my mom found. They were safety equipment that she painted black and put onto the sunglasses. But I grew up with this very kind of conspicuous, and not able to kind of participate in some of the things that a young boy would do. Playing sports, baseball, things like that, driving when I got to be 16. And so I became a musician. I definitely rebelled, and I won't dwell on that story, but I'll say I want to get into the point at which I start thinking in my 20s about, so I'd love science in school, and I start thinking in my 20s about wanting to be a doctor. And that's where I really want to start with you all. So this was an exploration process. This is around the year 2000, late 90s, that was very difficult to undertake. I wasn't sure what I didn't know. And so I did a lot of cold calling of offices of student life and offices of admission, trying to understand whether it would be possible for me to go to medical school. And I met with a lot of no's, a lot of very frank, no, I don't think that would be possible. I also met with some people who asked me some more questions, and I went to UCSF and spoke with them in person, and we looked at some pictures, which was really interesting. So I'm showing here as a picture of a chest X-ray, and so the question would be to me, an untrained reading a chest X-ray, can you see this? And of course, I don't know the answer to that because I don't know to what degree a person would need to see this. It turns out reading chest X-rays is pretty hard. You need to be able to see quite well. But then I'm pretty savvy with using magnification, using a computer, blowing things up. So I think my answer really to this one is I'm not so sure. And here's a picture of an EKG. Say, could you see this? And I don't know if those who have seen an EKG in person, they're quite small. And so, but I knew my answer to this was probably yes, probably with the right magnification. I think in practice in the hospital, if someone handed me this, I could take out the right tool and read it. And then I was shown this histology slide or a slide like it, just an image. Could you see this? And I think for me, for sure, the answer would be no. I had enough memories from biology class to know that microscopes were really, really challenging for me, and that wasn't going to work. But I was saying to these folks at this point, I don't want to be a pathologist. I want to do a cognitive specialty, like maybe internal medicine. And the answer really at the time was, well, that's not how it works, right? They have this idea, very strongly had an idea of pluripotency, that the medical student ought to be able to come out of medical school and do anything. I found myself thinking, well, I think there's probably plenty of people in medical school who might not be well suited to be a pediatrician or a psychiatrist or a surgeon. We're not talking about them, but that was the conversation. And then I read this on one of the school's websites, and then I started to find it on all the school's websites. And this is what's called the technical standards, and this is the category called observation. I'm just going to read it. It says, candidates must be able to observe demonstrations and participate in experiments of science, including but not limited to such things as dissection of cadavers, examination of specimens in anatomy, pathology, and microscopic study. These skills require the use of vision, hearing, and touch. And it goes on to talk about responding quickly in an emergency and a bunch of stuff that I read this and I thought, oh boy, okay, the answer now is categorically no. So that's a really big deal because now I've invested a lot. At this point, I'm not giving you the details, but at this point, I'm back in school doing my post-baccalaureate studies, planning to apply to medical school. So this was a real crisis. And at this point, what I did is, you can probably guess, is I started finding, I found one in particular, third-year student who had a visual disability. And she was really a lifeline. This is pre-social media. I can't tell you how hardening it is just to look at the comments on the main page of this conference, because I see people finding each other and announcing their presence. And so these connections were incredible to me at this point. And since then, I've spoken with many young people with the same question: can I do this? Right? Because you don't know what you don't know. So with that person, with her encouragement, I continued talking to medical schools, and a conversation with UCSF really turned around one particular individual who just brought the right people together and said, we may not know how to do this, but I think that this young person could probably help teach us how to do this. And I think the magical words kind of were like, is it possible? Is there a reasonable accommodation that we could arrange? And then I got in, and then I have to say that the first 2 years of school were quite straightforward, really successful. And that's because I knew how to be a student, and most of the first 2 years of medical school is classroom-based. The anatomy was a little bit inventive. I would go in before the rest of the class to take my exam because they used tiny colored flags to ask you to identify the structures, and I couldn't even see where the flags were. So I would just get down super close to the cadaver, and with my instruments, I would find the structures that the instructors wanted me to identify, and that's how they tested me. I did the histology tests with large photographs. I got a lot of them wrong because they were color-based, but I got enough other stuff right that the school really my first 2 years were a success. The problem was that I had spent so much time thinking about those first 2 years that I was completely floored by the clinical environment. And I was I'd worked so hard to figure out if I could be a doctor that I hadn't thought about the physical environment. But boy, I'm sure it's so obvious now. You couldn't come up with a worse environment for a learner with a visual impairment, because everything. So at UCSF, we have 3 hospitals. By definition, as a clinical medical student, you rotate between them and you rotate onto different services all the time. People on those services then proceed to go off shift and come on shift. People move around. There were walls of forms, and you're sort of a gopher. You need to be useful. So someone says, please go get the form. This is back in the days of forms. Get the form for patients who are on insulin and fasting for a procedure. And that's one of a million forms on a wall of forms. These are the kind of things that I found myself it was really challenging. or even just this. I'm showing a picture here of a crowded hospital corridor and the main nursing station, and I have so many memories of finally finding the nurse that I needed to talk with by just the grace of other people being kind, and then talking with her, and then turning around or maybe writing something and looking up, and she would be gone, and I'd be back to square one. Where any one of these people, there's probably 20 people in the image we're looking at here. Any one of these people could be Suzanne, the nurse that I had just met. So just a real challenge. This is a picture of us like a supply room. And you can imagine the team might say, like, go get a thoracentesis kit and meet us back here in 10 minutes. And I go into the supply room and just look at every single label on every single shelf, kind of scanning across, just unbelievably challenging, painful, and kind of absurd in retrospect. This is an ICU. In this picture, a lot of the medicines and the machines are labeled. And the reason I like this picture is it reminds me so much of one experience where on my first day in an ICU rotation, the attending said, I want you to go in this patient's room, the patient's completely sedated, and I want you to come out in 5 minutes and tell me everything you can tell me about this individual. So it's a great exercise, but for me, not having ever spent time in an ICU room, I had to get up, 3, 4, 5 inches away from every single one of the displays on every single one of the machines. Some of the drug labels on the IV bags that are hanging are really tiny. So there was no way that I was going to do that exercise in 5 minutes. This is a picture of an emergency room. There's several people attending to a patient, and there's a sign up on the wall. I can't read it in the picture because it's too small for me, but I know what the sign does is it identifies who should be where. Who should be on which side of the patient? And so, of course, as a student, I got this kind of thing wrong all of the time. This is a picture of a wall of medical charts, old-fashioned paper charts. And this was just another thing I had not thought about at all. So you take out, this is a pre-electronic health record, you take out a patient's chart and there's a bunch of tiny photocopied, faxed, handwritten stuff, completely unreadable, really, really challenging. And then this is a picture of Epic. And I had waited, I was so excited about the computerization of medical records, more than anyone probably. And of course, anyone who uses this knows you couldn't design a system that's harder to use for a person with a visual impairment. So I still, to this day, start at one side of the screen and scan across to the other sometimes to find functions that I can't remember the exact location and can't kind of zip right there because it's so counterintuitive and there's so much clutter. And this is a picture of a doctor sitting at a computer bank in the hospital. And I wanted to point out the sort of accommodations that I tried to mostly make for myself during the clinical training. And just having a place where I could set up a computer that I could see became like a real challenge because you're moving around so much. The VA, for instance, it takes, an act of Congress to drill into the wall and put like an arm. I wanted an extension arm in most settings so I could pull the display towards me. It took me a year to get even a larger than the tiny little 15-inch monitor at the time or smaller at my clinic. It took a whole year for me to just get a larger display. I actually wound up bringing a larger display myself to San Francisco General. So I really struggled with the accommodations in the clinical space. A couple thoughts about that I just in summary, I won't go into this because Lisa Meeks, who is going to speak later, has done so much incredible work on understanding the accommodation for trainees in health sciences. But a couple reflections, just to recap, that prior academic experience applies to the classroom learning components of health sciences training. It doesn't really apply to the clinical setting. You can't know. Administrators and faculty very likely will not anticipate the challenges in the non-classroom setting. And that question brings up the idea of disclosure by the applicant. It just makes it really, really a profound question. And I'm going to leave it there as a question because I'm sure we'll talk more about it. And I know Lisa will talk about it and has some data about it. Okay, so as a student and then trainee, I went on to do my residency at UCSF. I had a real I was constantly struck by the number of patients with disabilities and our inability to accommodate them, and the fact that we had absolutely no curriculum. It was almost a completely unacknowledged phenomenon. We didn't learn anything about prevalence of disability, and we certainly didn't talk about how we might deliver care differently. It wasn't part of the medical school curriculum, and it wasn't a part of the care delivery enterprise from what I could see. This is a study of offices in California conducted by Medi-Cal. And it's a few graphs. I'm just going to say the highlights out loud. That in one composite score, only 34% of practices met all of the the criteria for accessibility. The one that really spoke to me that I noticed first was the height adjustable exam table, which is this chart up in the upper right. So 8.4% of practices had a height adjustable exam table. For those, I mean, I'm sure most of you can either picture this or have been in this situation, but the old-fashioned exam tables are they're downright cruel. They're dangerous. They are impossible for many people to safely get on and off of. So it's a very visible manifestation of the lack of accessibility to care. So I mentioned the prevalence that I was noticing, and I want to talk a little bit about that just to kind of set it up for the rest of the day. This is a figure that describes that has the population broken up into age groups, and so the full height of the column represents how many people there are in that age group, and then there's a stacked bar within the column that represents how many people within that age group have a disability. And what they mean in this study, so we're going to talk more about definitions, but what they mean here is that you need help with an activity. So that's what we're measuring. Interestingly, so if you go to the far right of the chart, people over 85, 67% of people over 85 have one or more condition for which they require assistance, so ADL or IADL. So that is not surprising, and that's kind of the first way that most people, data that most people will learn or get about disability when they start to look into this. One of the things that I think is most interesting, though, is if you look at the group of 55 to 64-year-olds, that group has the largest absolute number of people with disabilities. They're 22.7% of that group. But because there's many more people in that age group than people over 85, it represents probably just eyeballing it here, it's 2 or 3 times as many people in the population with a disability. So that I find really telling. The group even below them, the 45 to 54-year-olds, and even below them, 35 to 44-year-olds, there are more absolute people with disabilities in those groups than in the over 85 group. So that just suggests that that this is a problem. This is not recognizing this and accommodating and training, and this is something that impacts our care for the full spectrum of the population. There's a study that came out last year, I think, by Rebecca Brown at UCSF that I found to be pretty profound. It's called the Health and Retirement Study, and it does a lot to kind of get at this 50 to 65-year-old group of people. So I wanted to share it because I think it's fascinating. So they took a group of patients. This is a lot of people. It's 6,800 people. They took a group of patients who were in their early 50s with no ADL or IADL limitations at the time of enrollment. And then they interviewed them every 2 years through age 64, asking about those activities and their ability to perform them unassisted. 46% of these folks were women, 80% were white, 29% had hypertension, 25% had osteoarthritis, 16% had depression. So for those of you who practice, that looks like a kind of common, typical, normal, like spread of chronic disease in this population. And what you see is that over the period of time that they observed these people, again, that was until they were age 65, you see people develop a pretty striking degree of limitation in one or more domains. So this chart is showing development onset of first ADL impairment is called. And it lists dressing, transferring, toileting, bathing, and eating. And the dressing is the top one. And by the time you get to 64 or 65, the proportion of people who had difficulty dressing is actually over 10%. The next chart here does the same thing for IADLs, and they are shopping for groceries, managing money, preparing meals, managing medicines, and making telephone calls is what they measured. And shopping for groceries was the highest one. And when you get to age 65, that's nearing 10% of people who've had developed a limitation that's caused them to be unable to do that. And if you combine all that stuff, you see this chart here, by the time you get to 65, that 22-ish% of people have developed a limitation in one of those. And this next flow chart describes what happens to that group. And I think in the interest of time, I'm going to keep going, because the implication here is simply that it's dynamic, that some people develop a functional limitation, and then some of them get better and some of them get worse, and some people it persists and stable. But that was another really interesting finding of this study, is that developing functional limitations is a dynamic thing, particularly in middle age. So I mentioned that I wanted to talk about a definition of disability that I found really useful. This comes from Margot Kuchel at UCSF. And I personally just, this has made my whole understanding of the topic just much easier to kind of frame in my head. So I wanted to share it. And the idea, so on the left-hand side here, it says pathology. And the example of pathology that I give is macular degeneration. Then the next over to the right says impairment. And the example that I give is decreased visual acuity. The next is functional limitation. And the example I give is can't read small type. And the last is disability. And the example I give is it can't read the prescription on a bottle. So again, so pathology on the left, and I have a little arrow that says this is where we spend all of our time. So those of us in the health sciences, we live there. We study macular degeneration. That's what we might teach you about in a medical school class. Patients live on the far right of this. And disability is really, it's not just, so the difference between functional limitation, which is can't read small type, and disability, is that disability is an interaction between that functional limitation and the environment. So a person with two people with the same functional limitation, unable to read small type, let's say, might have very different experience of disability. One of those people might have a doctor who knows that the pharmacy can put large print or braille labels on medicine bottles. Or they might have been to a living skills center where they learned how to orient and get around with a white cane. Or they might have a closed circuit television at home that lets them really, really enlarge their reading and read as much as they like, and the other person might not have that. So I found that to be a powerful distinction. There are extraordinary disparities in the care of patients with disabilities. These are well documented. 77% of adults with disabilities describe physical or programmatic barriers that limit access to health programs. 47% experience difficulty accessing primary care and preventive care. There's increased susceptibility to secondary health problems for a variety of reasons. There are poor health outcomes, and there is a very powerful intersection with poverty. I'm going to share a graphic about that, but 29.7% of people with disabilities were unemployed in the 2010 census. I'm sharing a graphic here from the New England Journal from a study that is now a few years old. It's from 2006, but I think it's a very powerful visual representation. Let's look at the bottom one of these two. They're essentially the same, but the bottom one is for women. And it has 4 lines by age group. The axes are functional limitations on the y-axis, and that is, as we discussed, that's needing assistance with one of those ADLs. And then the x-axis is where you are in relation to the poverty line. So on the left, the very left-hand side of the x-axis, you are at the poverty line or below. And then at the very right-hand end of the x-axis, that's 700% of the poverty line. So what you see is in that top group, those are folks over 85, women over 85. And 60% of those women have a functional limitation no matter what their income. So at a certain point, with age, we see a high prevalence of functional limitation. But let's look at the bottom line, and that is adults age 55 to 64. And in that group, it's just extraordinary. So if you look on the far right, it's probably 8% of people have a functional impairment. But if you look on the far left, where we're below the poverty line, it's close to 40%. It's 40% of patients have a functional impairment. Now, the reasons for this are incredibly dynamic, complex. You could tell several stories about this, and I would, it's really, I don't want to gloss over it, but you can imagine that this flows in both directions, but we know that there are disparities in care. And we know that there are income implications, job, employment, educational implications of having a disability. So it goes in both directions in a very complex way. Interestingly, back to that health and retirement study, when they looked at predictors of developing a functional impairment, the strongest one was, of course, low income. And that's something that I had come to recognize through being interested in this topic, but it was, I think this study does the best job of really highlighting that that's the case. So to get back to Pete's challenge to me, what is it about professionals with disabilities that maybe makes a difference? Just to summarize where I've hopefully brought us so far, the prevalence of disability is broad and diverse. Access to care for patients with disabilities is a crisis. Disparities in care are a crisis. And the care for patients with disabilities is underemphasized in health sciences training programs. So how do we, clinicians with disabilities, change the landscape? I've thought a lot about the idea of the identity that people have in terms of disability. And this may feel like it's stating the obvious to some of you, but I think it's really important. There is a spectrum. There are people on the left-hand side of this spectrum who have an established diagnosis, who identify with the term or the idea of disability, who would check that off on a form or raise their hand at a meeting or attend an activist interest group. And those folks typically know more than we do, by the way, about their condition when we see them in clinical settings. Then there's a group in the middle who have typically a chronic disease with an evolving functional impairment, right? They might have knee arthritis. They might have glaucoma. It might be age-related hearing loss. Those folks would never go attend. They don't feel like they're a part of a community. They are not activists around disability. They would very much like not to be associated with disability. And yet, they have functional impairments that have profound implications on their quality of life. And then you have people on the far end of the spectrum who have declining levels of function, and they're not even necessarily being acknowledged, not even necessarily aware. My premise really is that this group of people here on the left knows a lot, has discovered a lot about technology, different innovations to be independent. There is just a ton of experience here and a ton of innovation. And they have, and it's a relatively small group of people compared to the population or compared to this middle group. They have a lot to offer in terms of extending that knowledge, those accommodations to this broader group of people who have functional limitations but don't self-identify as having a disability. And I think that's where we live as self-identified, culturally competent health professionals with a disability. I think are likely to recognize a disability as a functional limitation, plus the environment to recognize that distinction that I made. They're likely to address disability independent of the pathology. So, for example, not just the knee arthritis, but also talking to a patient about mobility. They're likely to not just talk about the glaucoma, but also talk about reading and how you might accommodate. They're going to recognize that most people will not self-identify, but still need tools, accommodations, resources, insights, and acknowledgement. So I developed a curriculum as a student around care for patients, culturally competent care for patients with sensory impairments. And what I was going to do, there's a few more slides, but I'm going to stop actually because I want to leave time for questions. But the remainder of my slides really were just to make the point that there are actually, and these are available in the on the box folder that's associated with the main page of the event. But there are several accommodations, very practical, very learnable, very knowable accommodations around many different disabilities that we could be teaching and we could be implementing, and we should be uniformly across the board. So I'm skipping past these slides. Again, for many of you, they will not be rocket science, but they're incredibly important in terms of the care we give. I do want to give the final note on my own story, just to end here, which is to say that after my training, I one day looked at the UCSF webpage. This is probably 2013. At the technical standards that I showed you at the beginning, and they had added this very, very important language. And it just says, the School of Medicine provides reasonable accommodation in its academic programs to qualified individuals with disabilities. So that is the key to the conversation. It's still a challenging conversation, but that opens the door. This statement does not appear everywhere, to my knowledge, on the very essentially universal technical standards you see on medical school websites, but it does appear on most. I did sort of a spot check. So that I feel like is major progress, and I wanted to share that and end there. Thank you.
Nat, thank you so much for that wonderful talk. Really, so much of what you said resonated with me and my own personal experience. Just to address that last issue you said about messaging, there's so much outreach and work going on in this field across the nation, and yet the easiest thing, such low-hanging fruit, is to just put messaging on your website that says we encourage people with disabilities to apply to our program. I mean, I did like a recent audit of some of Stanford's websites, and despite all these ongoing diversity initiatives, barely any of the websites have a comment that says directly we encourage, underrepresented applicants to apply, or we support diversity, or we support disability. And it takes, 5 minutes to put that text up. And if you're doing those initiatives, people who are looking around at your programs will see that they are welcome there. They will feel like their application will be considered and taken seriously. And it makes all the difference. And we're just bad at it, I would say. Would you agree with that?
100%. And then the extension of that is that those applicants need to see faculty with disabilities on those websites and in the media.
Yeah, I mean, and that's Lisa Meeks at Michigan is doing such a good job with that, and her Docs with Disabilities podcast, just portraying doctors with disabilities, because we are around, but like you said, it's interesting about the self-identification with disability. Also, I think that it's totally true, as people age and accumulate disabilities, they're still sort of like not motivated at all, or reluctant to even say they have a disability or identify as disabled. And I think that, once you adopt that label for yourself, it opens up a whole world full of resources. So, I was going to say, like, I've always thought we see patients coming in sometimes with older patients from nursing homes, and they're really constipated. And some of them are so constipated to the point that they get what's called stercoral colitis. It's like an erosive inflammatory condition, and the stool will actually perforate through the intestine. I know this is gross, everybody, but I'm a GI doctor, so it's nothing for me. But they will actually like perforate their colon. I'm thinking, when I had my spinal cord injury, they taught me how to manage my bowels, but old people never get taught how to manage their bowels. They are sometimes like immobile and stuck at home, but nobody tells them about wheelchairs or fits them with the mobility device. No one is taught how to get old, right? And I think that's a big problem because when you get a disability and go into the hospital, you get OT, PT, rec therapy, all of this stuff. They set you up, and hopefully on discharge, you're like ready to go out into the world. But for older people, they're not taught any of that stuff, and it has a very negative outcome on their health and on their quality of life.
And they have, I would add, I agree, it's such a great example. There's a real, the identity change that comes with losing some ability to do something independently is, it's universal. Almost everyone experiences that, and it's universally terrible. And so as a doctor, we offer in a position of helping people navigate that. And we're just not good at it. We don't teach this. And it's there's actually a lot to doing it right. Um, I can't tell you how often I have the conversation with a patient who's had a few falls, let's say, because their gait is really just for the multifactorial reasons that gaits deteriorate, arthritis, balance, um, sensory neuropathy that develop in many older people. And I start raising, this happens probably at least once a week, I start raising the idea of using a cane. And the response is almost entirely, I mean, it's human to say, no, I'm not a person who uses a cane. That's not an identity shift that I can make right now. And that often I think is the end of the conversation, much to the detriment of that person's health and safety. The way that I have found to get through that, and I think this is, again, it's more or less common sense, but I don't think we do it, is to have the conversation about the activities that that person is missing. Let's say you can almost always find something that they were doing, walking to church, that they no longer feel safe and comfortable doing. And what I'll often do with the gait, with this question, and there's a corollary here for hearing, for vision, for cognition, for everything. But what I'll often do is have the person walk, and then I'll have them touch my hand, and then I'll take away my hand, and I'll bring it back, and I'll take it away, and I'll bring it back. Just to show that having that extra point in space, that extra proprioception makes them feel quite a bit more confident, and they walk faster, and they feel more safe. And then I say, that thing that I'm doing, that's the job of a cane. Perhaps we could think about just the one activity, just the walking to church that you're no longer doing. What if you had a cane just for that one activity? So kind of taking away from the identity question and thinking about just the independence question. So that's just a practical example about something that affects millions of people, that I really believe that a clinician with a disability is like inherently going to be more attuned to. And as I say that, I'm very aware there is a phenomenon that people who have a difference become sort of overtaxed by doing the work of representing that difference. That is probably most familiar right now among our colleagues who are African American, who are being asked to kind of be on every panel and
we call that the minority tax.
Right, exactly. And so when I talk about the value of being of people in the health sciences with disabilities, that's always sort of in the back of my head. I think it's important to be aware of, but I think that the value is too great. There's so much benefit to having patients see providers with disabilities, and to having providers be in the dialogue about how we deliver care, and talking about things like you and I were just talking about, because that then permeates the way that we deliver care.
Yeah, I found that my outlook towards patients changed completely after my spinal cord injury. I didn't do patient care for too long after that because I switched into radiology. But instead of thinking about a patient's diagnosis and how to manage it, I started thinking about their activities and how their life was impacted. I really love that strategy that you just talked about for patients. I've never been taught that before. The idea of like focusing on an activity rather than on like the mechanics of how to do that activity, uh, offering them like a real life example with an additional point of stability to kind of prove it to them or have them try it out on like a trial basis, like you said. Those are all just, like I said, things that I've never thought about. And I think that doctors with disabilities are more, um, much more prepared and focused on these sorts of like outcomes and activities. Um, so I want to talk about accommodations here. Some people have been writing about how to ask for accommodations as a student or a doctor with a disability. And when do you think, let's say, for an undergraduate student applying to medical school or nursing school, whatever, PhD, OT, so whatever, like when do you disclose your disability?
So I want to start by saying this is one opinion. I entered into the exploration and by starting with the disclosure because I really felt like I needed to test the possibility. I really didn't know if I was going to be able to go to medical school and going to be able to be a physician. And I figured out there's a place for me as a physician by talking to doctors and reading. And I think I felt pretty confident that if I can get through the training, I can get to a niche that will work well for me. But it was really hard to figure out if I could go through the training without asking questions about um, the activities and what accommodations might be possible. I also, two other points. One is I wound up going to UCSF because of the way they responded to my disclosure. So I think it is important. For me, it was important to be at a place that was interested in solving these problems with me, that was able to say, we actually have never had a student, and we can't find any other school that has. There are a few, of course, but they hadn't encountered, they couldn't identify their counterparts at other organizations that had students with visual impairment. And yet they said, we think we can figure this out. So I think disclosure allows you to maybe make a better match in terms of finding a place that likes the idea of working with you, that maybe is interested or thinks creatively. And then I'll leave it at that, because what's been interesting for me is that was the only way that I knew. And then after finishing my training, I learned that that the privacy around this is actually, for many people, super important, and to be able to go into an application process not feeling like this is the headline about me can actually be really important. And so at first I thought, I can't imagine not having those first two assets that I mentioned, not having gotten to vet the place and think about the match and think through the actual options. But there's enough information now out there about what's possible and how what accommodations have been available, what accommodations are considered to be sort of standard. Um, that I think those things really they do exist in a genuine tension. The way that I did it, the sort of testing the waters versus going into the application process without making that the headline. Those are both entirely reasonable arguments, and and they are going to exist in tension, and different people are going to have to arrive at their own answer. And the key here, of course, is to get a lot of opinions and find mentors, find people who are ahead of you with even roughly analogous situations, because there will be a lot of opinions. So you want to make sure that you're casting a wide net. There's many stories about people who kind of heard one strong opinion, and it can be almost destructive if it's particularly discouraging. So keep asking. That's like a really important thing in my own story. I didn't dwell on how many times I heard no. I heard no just a staggering amount of times. I remember one conversation with an admissions director at a medical school, and I told her, I said, I understand there's a woman at UCLA right now who's deaf. So could we talk about what an accommodation? So she has an interpreter. What might an accommodation look like for me that would be sort of the equivalent? Um, so she has someone interpreting what someone is saying. Could you envision someone saying to me that something was a certain color, or that we're reading something, or and the answer was no. And I don't think we would accommodate that young woman who's deaf either. So you will, people who are coming into this, you will hear discouraging things. That is just a fact. And so keep asking.
Yeah, so many things I want to say here. I also was told no by one residency program I really wanted to join. They looked at me in the wheelchair and with serious concern, not like, I don't think that they were trying to be mean, but they just saying, they looked at me and they said, I just don't see how you can do it. Like, look at you in the wheelchair, and people are hanging films. And back in the days when people were hanging films, they're hanging films, they're running around, they're going here, they're going there. It's so fast paced. You just can't do it. And sure enough, they did not accept me into their residency program. Um, you know, I think it takes an open-minded person and a person that has like the mindset of problem solving. There are certain people in life that are no people, and then there are certain people that are let's figure it out people.
Yeah.
And my program director at Stanford, Terry Desser, we just figured it out together, and looked at someone like interventional radiology, for example. I'm not going to be doing angiography myself. I'm not going to be scrubbing into procedures. So what did I do? I took the consult phone, which nobody wanted anyways. Like everybody hated the consult phone, but for me, it was actually cool because I got to talk to these clinicians. I reviewed the films. I presented to the attending. So it was like a win-win. I didn't have to do procedures or feel bad about it, and I was helping out the other residents by doing something that I could do, but they didn't want to do. And, if you can make those win-win situations, I think that is important. Regarding disclosure, I think for me, there wasn't a choice of whether or not to disclose when I showed up in my wheelchair for residency interviews. But some people with invisible disabilities, don't necessarily have to. And I think that is a tricky situation. And I don't know if this is the right answer, but I tell people to disclose if it's important to them, an important part of their identity, or uh, if they feel like it's relevant. And if their disability isn't really relevant, it's just something that they have to deal with, then I think that it's less important to disclose sort of prospectively.
Mm-hmm. I'm appalled at myself for smiling at your story, because it's such an unbelievable story. If you think about how little imagination would it take to figure out how you might review films that are usually hung high up on a wall.
Yeah.
It so lacks imagination, but it's an amazing example.
I know I met a woman who was an OB-GYN residency, and she had issues with hand strength. And so she would tie a knot when she was suturing a little different with her hands, like the way she would position her fingers. And there was nothing wrong with her knots. They were fine. But the residents in the program above her were very upset that she wasn't doing it the exact way that they told her to.
Yep.
Some of the attendings didn't care. They were like, all right, tie a knot however you want to tie a knot. But like some people were very rigid. Like you have to do it this way, and that is the way. And if you can't do it that way, then you don't belong here. And she left. She went and did an internal medicine residency. and it's just unfathomable that a small thing like that can force somebody to find another career.
Wow. And yet that is sort of that's one of the major parts of the legacy of the training system that we come from. So it's a good example.
And I just want to acknowledge before we go to our break that I come from a place of privilege, and it is not easy living with a disability, working with a disability. I don't judge people who can't do it because it is so difficult. I have money, I have family, I have health insurance, I have a good job, I have hospital volunteers that help me throughout the day. Uh, you know, so many. I have long-term care insurance that pays for my caregivers. I mean, I pay 50 something $1,000 a year for caregivers to help me out, and that gets reimbursed. So when somebody says to me, "That's great, you're working, you're not content to sit at home and collect your disability check," it makes me mad, that stereotype, because it is so hard. And so that really bothers me when people judge disabled people that don't have the ability to work. And so I think that I just want to acknowledge that privilege, and I don't want people to get the idea that like it's easy and everyone can do it, and if you try hard enough and push through, you can accomplish this. Because sometimes the stars don't align.
Thanks for that. That's a really important point, Pete.